You are in the ICU. It is 2 in the morning.
Oh, the absolute worst time for things to go sideways.
Always, right. And you have a patient who, I mean, they came in totally healthy just a few hours ago, but they suffered a devastating trauma.
Yeah.
They are intubated. The ventilator is completely breathing for them. And right outside those glass doors of the room, a family is just reeling from this sudden, unimaginable tragedy.
It is the heaviest environment you can imagine.
It really is. And as the bedside nurse, you are watching the focus in that room start to shift. The trajectory is changing from, saving a life to the very real possibility of organ donation.
Right.
So the question is, do you know exactly what your role is in that moment? And honestly, even more importantly, do you know what you should absolutely never say to that family?
That moment is, it is arguably one of the heaviest, most complicated transitions you will ever face at the bedside.
Oh, for sure.
Because the clinical requirements just completely flip. The emotional weight is staggering, and the ethical lines, they are incredibly rigid.
Yeah, newer nurses often feel like the rug has just been pulled out from under them.
Exactly. Because everything they were doing to save the patient suddenly changes into a completely different set of interventions.
Which is exactly why we are unpacking it today. So, welcome to an episode of the Super Nurse Podcast.
We are so glad you're here.
Now, this show is created by Brooke Wallace. She is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author.
But we should explicitly state right up front that we are not Brooke Wallace.
Right, definitely not her.
But this entire conversation is built strictly from her bedside knowledge, her clinical notes, and, her signature teaching style.
We are basically here to help nursing students and new nurses bridge that massive gap between textbook theory and real, messy patient care.
Yeah, taking what you learn in school and applying it to the actual bedside.
Exactly. And before we get into the clinical grit, make sure you subscribe and watch the companion comic book-based video for this episode on YouTube.
It is so good.
It really is. The link is in the description, and you can find it on our channel, Super Nurse Comics.
So our mission for this exploration is to break down the organ donation process.
Right.
But specifically from the perspective of the bedside nurse.
Right, because that is where the rubber meets the road.
Exactly. We are going to look at the role of the organ procurement coordinator, the OPC, along with the clinical triggers you need to watch for.
And the intense physiological management of the donor, which is wild, plus the emotional realities of working these really challenging shifts.
So let's start at the beginning.
Okay, yeah. Because if early identification is like the very first domino to fall in this process, how does a bedside nurse actually know when it is time to flick that domino and make the call?
That is the million-dollar question.
Right. Like, are there standardized signs, or is it just a gut feeling that, the patient isn't going to make it?
There's zero guesswork involved.
None.
Really?
Yeah.
Not at all. Nope. Clinical experience shows that hospitals are actually required by CMS regulations to notify their local organ procurement organization, the OPO, when a patient meets very specific criteria.
Okay, so it's a hard rule.
It is a strict regulatory mandate. They are known as clinical triggers, and they are designed to ensure no potential donor falls through the cracks.
Okay, so let's translate that into plain English for the bedside assessment. Like, what are you actually looking for?
You are looking at a patient who has suffered a massive neurological insult.
So like an anoxic brain injury.
Exactly. Maybe they had a prolonged cardiac arrest out in the field, meaning their brain went without oxygen for way too long and the cells are just swelling.
Or it could be a severe traumatic brain injury from a car accident or a massive hemorrhagic stroke.
Right. And they're completely dependent on the ventilator. Then, when you perform your neuroassessment, their Glasgow Coma Scale, their GCS, is a 5 or less.
A 5 or less. That is profound neurological impairment.
It is. When you do your checks, there is no eye-opening to pain. There is no verbal response over the endotracheal tube.
Right. They are completely unresponsive.
And the motor response is either absent, or you might just see, abnormal extension, like decerebrate posturing.
So that is one trigger.
Yeah.
But there is another major one, right?
Yes. The other major trigger is when the care team or the family initiates a conversation about withdrawing life support or, making the patient do not resuscitate.
Okay, so when you see this pattern, devastating brain injury, vent-dependent, low GCS, or talk of withdrawing care, what is your job?
Your immediate job is to pick up the phone and call the OPO triage line.
And a critical point that newer nurses sometimes misunderstand is the timing of that call.
Oh, absolutely.
You do not wait for the patient to be pronounced dead, and you definitely do not wait for the family to ask about it.
No, early referral is vital. The organ procurement organization needs time.
Like a lot of time.
Yeah. Hours. They need hours to discreetly review the patient's medical history and check state donor registries to see if the patient already consented on their driver's license.
And they have to screen for rule-outs, right?
Exactly. They're looking for specific metastatic cancers or like systemic infections that would automatically disqualify the patient.
So they are working quietly in the background, reviewing the chart, while you and the hospital team are still doing literally everything medically possible to save the patient's life.
That is exactly how it works.
But wait, if I've been with this family for, say, 12 hours, I'm holding their hands and I know the prognosis is 0.
Yeah,
Keeping quiet just feels completely counterintuitive.
it really does.
Wouldn't it give them some comfort right now if I just, gently asked if they've considered organ donation? It feels like it could save time and offer them a silver lining.
I mean, that impulse makes complete sense. As a compassionate caregiver, you want to help them find meaning.
Right.
But doing so violates the absolute most critical boundary in this entire process.
It's a huge boundary.
And this rule is strictly bound by ethics, the preservation of family trust, and legal hospital protocols. The bedside nurse must never, under any circumstances, mention organ donation to the family.
Never. It is the absolute rule. But I think we need to explain the why behind it, because once you understand the bedside logic, it really clicks.
Let's break it down. There are 3 distinct reasons why the bedside nurse is prohibited from initiating that conversation.
Okay, what is the first one?
The first is the conflict of interest. The hospital team's only mandate is to save that patient's life.
Period.
Right. If you, the nurse who just finished pushing life-saving medications and adjusting the vent, suddenly pivot and ask about organ donation.
Oh, I see. The family might mistakenly believe the hospital has just given up on their loved one just to harvest their organs.
Exactly. You can never, ever allow a family to doubt your commitment to saving the person in that bed.
Wow. Yeah, that conflict of interest is huge. And the second reason is the danger of offering false hope, right?
Yeah. As the bedside nurse, you don't actually know if that patient is medically eligible to donate.
Because they might have a hidden medical history.
Right. An obscure malignancy or an infectious disease like active tuberculosis that completely rules them out.
Oh, man. The last thing you want to do is offer this grieving family a chance for their loved one to leave a hero's legacy, only to have the OPO review the chart an hour later and say, actually, the patient isn't a candidate.
It is devastating.
Yeah.
You have just traumatized that family twice.
That makes total sense. And the third reason?
The third reason really comes down to specialized training.
Like, bedside nurses are brilliant at intensive care.
Oh, they are amazing.
Yeah.
But they do not have the complex, hyper-specific answers about the donation procedure itself.
Because when the topic of donation is raised, families immediately have logistical and emotional questions.
So many questions. How long will the surgery take? Will there be a closed casket at the funeral?
Does our insurance have to pay for the organ recovery?
Yes. And if a bedside nurse tries to answer these and guesses incorrectly, it destroys the family's trust in the entire healthcare system.
So, if the bedside nurse is completely removed from the request process, how does the conversation actually happen?
That is the role of the organ procurement coordinator, the OPC.
Okay, tell us about them.
What clinical experience tells us is that OPCs are highly trained specialists. And interestingly, they are often experienced ICU nurses, paramedics, or respiratory therapists who have transitioned into this specialized field.
Oh, so they know the ICU environment intimately.
They absolutely do. And their sole job is to evaluate the donor, extensively review the chart, run the rule-outs, and act as the designated requester.
The designated requester. I like that term.
Yeah, they are uniquely trained in grief counseling and crisis communication. They approach the family to discuss donation only after the medical team determines the patient is a candidate and the timing is completely appropriate.
It sounds a lot like specialized air traffic control.
Oh, that is a great way to think about it.
Right. Like the bedside nurse is flying the plane, keeping the patient stable. But when the flight path changes from recovery to legacy, The OPC steps into the tower to guide the complex landing and coordinate all those moving parts.
That analogy perfectly captures the transition. Because once that OPC steps in and secures consent from the family, your clinical mindset at the bedside has to dramatically shift.
We are moving from saving a life to saving organs.
Exactly. And to grasp the mechanics of this, we need to translate the two main donation pathways into plain English.
Let's start with donation after brain death, or DBD.
Okay. So in a GBD scenario, the patient has been declared legally and neurologically dead based on strict clinical testing.
Like an apnea test or a brain perfusion scan, right?
Right. But their heart is still beating because they're mechanically supported by the ventilator and, a whole web of IV medications.
But the physiological reality of what happens to a body during brain death is intense.
It is wild. What the evidence tells us is that as the brain swells inside the rigid skull, it has literally nowhere to go but down.
Yeah, and it eventually herniates through the foramen magnum at the base of the skull, physically crushing the brainstem.
And the moment that herniation happens, the body experiences an autonomic storm.
Wait, so they just crash out of nowhere?
Well, the sympathetic nervous system panics. It releases a massive surge of catecholamines, epinephrine, and norepinephrine.
So the patient's blood pressure skyrockets, and their heart rate spikes.
Yes, but it is just a final chaotic flare. Because once the brainstem is completely crushed, the central command center is totally gone.
And all that sympathetic tone just vanishes.
Completely. The patient's blood vessels massively dilate, and their blood pressure absolutely crashes.
That is terrifying to watch.
Furthermore, the pituitary gland, which sits right at the base of the brain, is destroyed.
And that pituitary destruction is why you suddenly see the patient's urine output shoot up to like a liter or two an hour.
Yes. Without the pituitary gland, the body stops producing antidiuretic hormone, or ADH.
So the patient goes into diabetes insipidus.
Exactly. They are literally dumping all of their free water into the Foley catheter.
Which leads to massive fluid shifts and chaotic electrolyte imbalances, right? Specifically, severe hypernatremia.
You got it. So your bedside tasks completely pivot to manage this physiological collapse.
Usually you are transitioned to a 1-to-1 patient ratio at this point.
Because you are now aggressively maximizing organ function.
Yeah.
You will be hanging heavy vasopressors like norepinephrine or vasopressin.
Just to maintain a mean arterial pressure high enough to keep the kidneys and liver perfused with blood.
Right. And you are also replacing all that lost fluid, managing electrolyte drips to replace the potassium and magnesium they are dumping.
And likely initiating what is often called a T4 protocol, yeah.
Yes, the T4 protocol.
Yeah.
Since the pituitary is gone, the thyroid stops working too.
So you are suddenly running intravenous levothyroxine, insulin drips to manage the stress-induced hyperglycemia, and steroids to reduce systemic inflammation.
It is a massive shift in care. On top of all those drips, you will be drawing frequent, highly specific labs that you just don't normally draw for a standard ICU patient.
Like what kind of labs?
Well, the OPC will order serologies to check for undetected viruses.
And ABO blood typing to ensure the organs match the recipient's blood type.
Right. And HLA tissue typing. Human leukocyte antigens are proteins on the cells, and matching these between the donor and recipient minimizes the chance the recipient's immune system will reject the new organ.
And you are also assisting the OPC with bedside diagnostics, right?
Oh, yeah. They might need an echocardiogram at 2 in the morning to evaluate the ejection fraction of the heart.
Or a bronchoscopy so the surgeon can visually inspect the lungs for infection or damage.
You are working constantly to stave off cardiopulmonary arrest before they can make it to the operating room.
It creates a profound cognitive dissonance, especially for a newer nurse.
I can only imagine.
I mean, it feels incredibly strange and honestly intimidating to be aggressively treating, drawing labs, and titrating life-saving drips on a patient who has already been pronounced legally dead.
How does a nurse even process that? You are watching the monitor, tweaking a vasopressor, treating a blood pressure, but the person is gone.
You process it by shifting your focus to the endpoint. You are no longer treating the patient in the bed to wake them up.
Okay, you're right.
You are treating the recipient who is currently sitting in another hospital, desperately waiting for that organ. You are preserving viability so a mother can get a new liver or a child can get a new heart.
That is a beautiful way to frame it. So that covers the brain death pathway. Let's look at the second pathway. Donation after circulatory death, or DCD.
Yeah, the bedside nurse's role here is deeply emotional, and the clinical mechanics are completely different.
Right. So in a DCD case, the patient does not meet the strict criteria for brain death.
So they might still have a few intact brainstem reflexes, like a weak gag reflex or occasional spontaneous breaths.
But they have a non-survivable injury, and the family has made the incredibly difficult decision to withdraw life support and transition the patient to comfort care.
So instead of maximizing organs with vasopressors and thyroid protocols in the ICU, the bedside nurse actually accompanies the patient from the ICU down to the operating room.
Yes, and the environment in the OR is intensely quiet and respectful.
As the bedside nurse, you are administering comfort medications like morphine or Ativan per your hospital's end-of-life protocol.
Just to ensure the patient feels absolutely no air hunger or distress.
Right. And you also administer a large, specific dose of heparin intravenously just before or immediately after the terminal extubation.
Wait, heparin. Why a blood thinner right before withdrawing care?
The physiological reason for the heparin is crucial. When the breathing tube is removed and the patient's heart rate and blood pressure begin to naturally drop during the dying process, their circulation becomes extremely sluggish.
Oh, I see.
Without heparin, the blood would begin forming microscopic clots or microthrombi inside the tiny capillary beds of the kidneys, liver, and pancreas.
And those microthrombi would permanently destroy the organs before they could even be recovered.
Exactly. The heparin prevents the clotting cascade, ensuring the organs remain viable.
That makes perfect sense. So you assist the respiratory therapist with removing the breathing tube right there in the OR. And then you wait.
The family is often present in the room or saying their final goodbyes just outside in a designated area.
And if the patient's heart stops and they pass away within the allotted time frame, which is usually 60 to 90 minutes, depending on the organ, the attending physician declares cardiac death.
The physician and the family step away, and the strict standoff period of about 5 minutes is observed.
That is just to ensure the heart does not auto-resuscitate, right?
Yes. And only after that standoff period does the opioid recovery team immediately step in to begin the surgery.
But what happens if the patient's heart is too strong and they do not pass away within that 60 to 90-minute window?
Then the donation cannot safely proceed. The prolonged period of low oxygen and low blood pressure will have caused too much ischemic damage to the organs, making them unsafe to transplant.
Oh, that is heartbreaking.
It is. In that case, the surgical recovery team stands down. The patient is moved back to their ICU room or a dedicated comfort care room, and you continue to provide standard, compassionate end-of-life care until they naturally pass.
The emotional weight of this entire process cannot be overstated.
Not at all.
When we look at the reality of trauma and ICU nursing, there's a recurring heartbreaking theme. A patient comes in completely healthy, they suffer a tragic random accident, and despite your absolute best, most aggressive efforts.
The CPR, the massive blood transfusions, the rapid interventions.
Right. Despite all of that, they cannot be saved.
And nursing literature and clinical experience highlight that ICU nurses must develop a thick skin to survive in this specialty.
But we have to define what that actually means in a healthy, sustainable way.
Yeah, developing a thick skin does not mean you become cold, calloused, or stop caring.
No, it is about professional boundary setting. As a nurse, your clinical role with a patient ends when that patient can no longer be saved.
You are not their family member. You are the healthcare provider.
And you have to find a way to consciously close that door emotionally. You process the grief, you honor the loss, but you have to put it to rest in your heart.
You do this so you can turn around, wash your hands, step into the next room, and be fully present to save the next patient.
Because if you dwell entirely in the tragedy of the one you lost, you will have absolutely nothing left for the two patients you might actually save today.
That is so true, and that is exactly where the profound silver lining of the organ donation process exists.
The true beauty of the OPC's work and the donation process itself is that it provides a tangible way for a senseless, tragic death to become a miracle for the living.
It takes the absolute darkest moment of a family's life, a moment where they feel completely powerless, and offers them just a sliver of light.
They get to know that their loved one's final act was heroic.
And it offers that same light to the nurses who cared for them, too.
Oh, absolutely.
You get to know that your exhausting, heartbreaking 12-hour shift, all those complex drips you managed, all those labs you drew, they resulted in someone else, maybe 3 or 4, someone else is getting a second chance at life.
Okay, let's summarize the vital bedside actions we've covered today so you can walk into your next shift with confidence.
A good idea.
First, recognize the clinical triggers. If your patient has a devastating neurological injury, is dependent on the ventilator, and has a DCS of 5 or less, You need to recognize that pattern immediately.
Second, call the OPO triage line early. Do not wait for a death pronouncement, and do not wait for the family to bring it up. Early referral is a CMS requirement.
Third, and perhaps most importantly, never bring up donation to the family yourself.
Leave that conversation entirely to the highly trained OPC, the designated requester.
Right. This protects the family's trust, avoids any conflict of interest, and prevents the devastation of false hope.
And finally, be prepared for your clinical role to dramatically shift. Once consent is given, you are moving from saving a life to aggressively stabilizing hemodynamics.
You are managing vasopressors, correcting extreme electrolyte shifts from diabetes insipidus, and maximizing organ function to protect those tissues for the recipient.
The goal here is that you walk away from this discussion feeling empowered. We want you thinking, okay, this matters, but it actually makes sense now, and I can use it at the bedside.
Because while organ donation cases are emotionally heavy, and they are incredibly clinically complex, when you take part in one, you are participating in one of the most remarkable legacies a human being can possibly leave behind.
It is the ultimate gift, and you are the guardian of that process at the bedside.
Thank you so much for joining us. Remember to check out the video version of this discussion on YouTube at Super Nurse Comics.
Please like, subscribe, and leave a comment to let us know what you thought.
And don't forget to visit supernurse.ai for amazing resources designed specifically to help you connect textbook knowledge to real patient care.
And become the super nurse you were born to be. But before we go, we want to leave you with one strong, practical takeaway to mull over.
We talked about the shift from treating the patient to treating the organ for a recipient.
But think about the profound nature of what you are actually doing. When you are hanging those pressors and drawing those HLA tissue typing labs on a patient who has been declared legally dead, you are actively providing vital nursing care to a person you will never, ever meet.
You are caring for the recipient through the donor.
How does that change the way you view your impact as an ICU nurse? See you next time.